Welcome to the Shockwave Therapy podcast. My name is James Woolwich, osteopath and clinical director at the Abbeyfields Clinic in Suffolk. We will be trying to demystify the concept of shockwave treatment whilst bringing together experts in their field to discuss the latest research. If you are deciding on whether to add this modality into your clinic or just improve the way you deliver it, then we hope this is the podcast for you. Today we're talking to Ove Indergaard of Indergaard Physiotherapy in Leeds in the UK. Originally from Norway, he trained as a physiotherapist in 1999 at the University of Bradford before completing a Masters in Sports and Exercise Injury Management at Leeds Metropolitan University in 2003. He's one of the few physios to achieve the Association of Chartered Physiotherapists in Sports and Exercise Medicine's Gold Accreditation. He's got a vast amount of experience in elite sport, working with, amongst others, the GB Judo team, England Badminton. His focus is providing good quality care through research and some advanced technologies like Shockwave. He holds numerous certifications, including membership of the Society of Musculoskeletal Medicine, functional range release and conditioning, anatomy and motion, etc. He's an experienced specialist and educator in shockwave therapy in this country and abroad. Today we will be focusing on his experience with tennis elbow. He sees lots of these patients and talks widely on the subject, so it'd be really interesting to have his take on tennis elbow and with particular shockwave today. Thanks, Uwe. Thanks for joining me.
How are you?
I'm alright, thanks. Thanks for joining me today.
It's an absolute pleasure.
So we are principally going to talk about tennis elbow today because the podcasts have gone a little bit up and down over the time that we've been doing, and I think I'm trying to take it into a position where we're talking about conditions. So this is sort of one of the first ones that I'm thinking about doing, which is you talking about tennis elbow. And the reason why I asked you, obviously, because now you're a world famous superstar on tennis elbow webinars. So you just did a webinar that was how many people on it?
I think there's about 500 I was active live, but there were 1,200 registered, and they all got a recording of it and stuff. So that was pretty cool. It was a bit of a novel experience, but
that is pretty impressive.
It was good.
So, but before we start, can you just give everyone, as we do, can you give us a roundup of what you're all about, where you are, and so on and so forth?
Yeah, sure. Yes, my name is Ove Indergaard. I'm a chartered physiotherapist. My clinic is based in Leeds, and I originally came from Norway, studied here in Yorkshire, and then ended up staying for various reasons. I guess through the years I've been involved with some elite sports and kind of specialised in that at some stage, and then from there on involved my practice a little bit. These days, a lot of it is chronic conditions, I guess. I see a lot of second opinion stuff. People who have been elsewhere and come back to the clinic here, both from a movement point of view, do a lot of shockwave these days as well. But it's a mixture of conditions, and there's a general practice, I guess.
Okay.
In that sense.
How long have you been in your clinic? Did you just tell me that? Have I just missed that? But how long have you been there?
The clinic's been here in Leeds for about 16 years now.
Okay.
So I've been in practice for 21 years.
Don't look that old.
I came to the UK about 24, 25 years ago.
Right. Wow. That's a fair amount of time. And just for everyone who might be watching this on YouTube, what are those fancy looking machines behind you? Because that's a particularly nice one.
Oh, right, yes. So the one that you can see in the back there with the black screen is the new Stolz Magneto-led extracorporeal magnetotransduction therapy.
Very nice, easy for you to say.
We just got about a month ago.
Yeah.
And then the other stuff is my shockwave setup, which is the Stolz MP50 radial machine. And then I have the T-top focused device. I've got the V-actor, and I've got various types of transmitters for my radial as well that I use quite extensively. Sure.
Okay. So for those that I mean I'm not particularly as an osteopath. I don't happen to see too many tennis elbows. So I'm going to be all learning today. So assume everyone listening to you is completely without knowledge. Just can you give everyone the last thing I remember learning at college was ECRB, blah blah blah. It's probably well out of date, and I have no idea what I'm talking about. So can you just give everyone a quick roundup of tennis elbow pathology, anatomy, etc.?
If from my experience with tennis elbows is not so much tennis players, I guess. I do see a lot of weightlifters and CrossFit athletes, and they usually come in with problems. The other group that are quite prevalent is, for me at least, manual workers, people who are using hand tools, and they tend to come in with these things as well. So if we then talk about like how, what kind of condition it is, we know that it's kind of a degenerative condition, it's an overload condition, and like you said, it's the ECRB, the extensor radialis carpi.
So that's still relevant. I'm not too out of date then.
No, it's still the tendon. So the common extensor tendon is made up of that and the extensor digitorum tendons.
Right.
The most important one is the ECRB, and it, you know, like if you look at the studies on it, it kind of ducks under the digitorum tendon and becomes a deeper part of the common extensor tendon.
Right.
And that has a couple of really important points to it, because one, that's usually where people get problems. Rather than the superficial parts on the attachment on the epicondyle. Yeah. And the second part is that it kind of articulates with the elbow joint on the underside of that tendon. So, you know, there's several factors involved with the tennis elbow, but one of them is the biomechanical side, and it has a heavy biomechanical side to it. The ECRB also integrates with the joint capsule. So.
Oh, okay. I didn't know that. Right. Okay.
So that's one part of it. Supinator takes some fibers off it as well. So when you think about all these things that you do, wrist extension, gripping, and twisting in your wrist, all of that involves and creates shear forces around the elbow. So there's a lot of forces that go through there.
Right.
And I think that's a huge part of why it's such an exposed tendon. The other thing that I find quite important with tennis elbow is that it's connected to the rest of the arm and the neck and the back and having all these connections. And, you know, like I'm a bit hesitant to talk about, you know, the anatomy trains and things like that, because we're not 100% sure whether that is actually a thing or not.
Yeah.
But there is some form of, you know, transmission of forces through the upper limb, right?
Yeah.
So some of it's coming, you know, when you grip, there's a joint action between your flexors and extensors in your wrist.
Yeah.
Bicep and triceps activity. There's also some deltoid activity. So soon, when you start to manipulate your arm around in space, all these muscles work together. And so we know that to be able to move our shoulders properly, we need to have good stability and strength around the shoulder girdle and things as well.
Yeah.
And so we then have, you know, some form of transmission of forces through the whole arm. So when we're talking about treating it, I think that's a really, really important part of it. The other two things that are quite important with tennis elbow as well, I feel, is that it becomes usually very sensitized. So the area itself has quite a lot of nerves coming into it.
Yeah.
So you have the radial nerve, obviously on the back, and then on the inside of it, you've got the ulnar nerve coming in, and so the radial nerve is in really close proximity to them, can get a little bit irritated in the muscles there too. So sometimes you get an overlap of compression on that too, and that can make it really, really sensitive. We know that the area becomes really hypersensitive, and you see that with your tennis elbows that come into the clinic, right? You press on the epicondyle and they fly through the roof. So there is an element of that as well, and you know, whether there's some central sensitization involved in there, I would say that's quite a high probability on top of the biomechanical.
Do you do any neural gliding stretches with your tennis elbow stuff? I know my physio colleague does it here, and he's quite keen on that with tennis elbow.
Yeah, you know, like when we assess it, obviously we do the standard wrist extension, middle finger extension, grip testing and things like that, and the palpation. But we also want to know if there's other things going on, right? Yeah. So you want to make sure that there is no nerve gliding issues. You know, we screen for that, and if there isn't a problem there, we know that that's not an issue. But if it is, then, you know, that's probably where we're going to start. We're going to start to desensitize that and see if we can create some better gliding. And we also look higher up into the system as well, into the neck area, and rule out any complaints from there as well.
Okay.
So it is a highly complex area. And I mean, the final thing as well is how it integrates and functions. So we know one of the biggest compensations that happen is that when you start gripping, instead of just gripping straight, you start gripping with a flexion. Yeah. And that has an impact on the flexor muscles and their connections in post-transmission. I often find this in the CrossFit is where if they haven't got the grip properly, then they can't recruit the lats properly either. So then the grip impacts the shoulder function, and you can't really, get that pull up
right.
in a good way, and then they start with compensations, and then they break down somewhere along the line.
Right. Okay.
And
I'm always tempted with CrossFit athletes just to suggest that they stop doing it. Actually.
Well, do you know what? Like, it's once you get going with it, they usually listen quite well.
Do they?
And you start, what I demonstrate to them, if they get the grip back, this is what can happen. And I teach them how to improve the lats better, but you have to get the shoulder in the right position.
Yeah.
And with that, it's what the grip does then. And we know from lots of research now that the shoulder and the grip is massively involved together.
Right.
So that you haven't got a grip, you probably have a shoulder problem or a shoulder stability issue.
Oh, right. There's been some research on that. Reduced grip strength with poor shoulder function.
So now I mentioned in the webinar, there's 2 or 3 papers that look at how the grip and the rotator cuff is linked. So if your grip is weak, your rotator cuff will be weak too. So there seems to be some form of co-contraction in there.
Or your nervous system is probably monitoring it, saying there's a weakness there, so we're not going to allow you to transmit force through the whole arm.
Yeah, I think so. Yeah, I think there's definitely some form of joint transmission issue,
right?
Or force transmission issue between the grip and the shoulder, which makes sense, right?
Yeah. So
if you're hanging off a bar and you're about to do pull up,
yeah.
It's kind of it filters in, like through the rest of the arm and how you activate.
All right, interesting.
How that happens, I'm not entirely sure, but it's certainly something that I show in clinic a lot.
Well, I think by the fact that you've talked that through, that goes to the heart of what I often bang on about when we're teaching, and I certainly say when I'm teaching, is that we're supposed to be talking about Shockwave, and we spent the last 7 minutes talking about anything but Shockwave, because Shockwave has become this sort of one answer, put the Shockwave on and hope for the best, right? And then I'm always trying to tell people that it's only as good as the rehab and the loading and your mechanical stuff is alongside it, right? So as you've just emphasised, if you don't look at all that stuff and you put the Shockwave on and it doesn't respond that well, everyone blames the Shockwave. Whereas actually the reality is you should blame the practitioner for being totally myopic and going, right, well, I've got a machine, I'm just going to put it on the elbow. So it's a good start that you started off with that, right? Yeah.
Yeah, so we see that through the body, don't we? Where the if you don't add the exercises to the Shockwave, it's less effective.
Yeah.
So that's part and parcel. But don't forget about being a practitioner just because you got a Shockwave.
No, indeed, yeah.
Your clinical skills in diagnosing movement problems and testing the area is so important. And then your rehabs.
But that was for us oldies. That was how ultrasound became about 20 years ago, wasn't it? Everyone would get an ultrasound machine, just get incredibly lazy and just go wiping it on the sorbits, and that's what it became, a cure-all for everything else for lazy people. But anyway, enough of my opinions. So if someone's coming to see you with tennis elbow over 3 months, and you've gone through some of the things that you've just suggested there, you've checked them out, they've got good neural glide, they haven't got anything too complicated, they've just taken up a new thing and they've overloaded the tendon. So how do you then go about building, your treatment plan with the patient using Shockwave? What is your go-to average kind of approach for this? Using focus, radial, what kind of things do you do? Your go-to things?
So one of the kind of the key things that I haven't touched upon yet is the thumb. Okay, so for me to be able to grip, the thumb.
Oh right, okay, all right.
So follow me, right? So when you spend a lot of time gripping, your hand is kind of held in a bit of a claw.
Yeah.
Okay? A lot of people spend lots of time on keyboards and they're in their claw, and so they tend to get really stiff around the end. So muscle-wise, I tend to find there's a lot of stiffness in the hand and they can't really spread the hand properly.
Right.
Okay? So this is just something
I'm finding this mesmerising. I've never heard of this stuff. This is great. I'm going to suddenly start getting a load of tennis elbow patients in this week. It's always how it goes, right?
So when we then get if you're in the claw position, right, you're going to overuse the kind of flexor group in here.
Yeah.
So technically, that gripping, that motor control issue that we see, kind of becomes a learned behaviour and a motor pattern. And so to get rid of that, if there is some myofascial things, we need to look into the forearm, whether that's got the extensibility that it needs. And with that is the thumb, okay? So the muscles come down here and the thumb needs to spread. And if you can't get out of the claw position, I bet you can't get full wrist extension either.
All right, okay.
So then every time you're doing stuff, these muscles are having to work overtime.
You can feel that as you're trying to do that, right? So
Yeah, so then they're working overtime all the time. So that becomes a factor then to why they might have a lot of overactivity pulling on this tendon all the time and creating this pain and discomfort.
Right, okay.
So I try to alleviate that. And so, for the treatment of the first joint in the thumb, right, we tend to do some radial work across the thumb.
Yeah.
And if it's really stiff and it's got like some arthritic elements to it, then I might even focus that. Purely because I want that wrist to be nice and free.
As in focus shockwave, yeah?
Hey?
As in focus shockwave on the thumb, you do, right?
Yeah, focus on the thumb. So start off with the radial and all the soft tissue work into there. Then I check and see if there's some improvement in mobility, the wrist gets better. And then once we've got that, and if there is, like, you do the shear test and stuff and there's still pain in there, then I might even shockwave that and treat that as part of the overall picture.
Right.
Okay, because that's important to me. There's no point releasing all of this for it to just start building up again because or tension or movement patterns and things like that.
Sure.
That's important. Then exercises follow that. Okay, so I use wedges and things like that, and wrist immobilizations where I put a wedge, a little like foam yoga block or something underneath the thumb, and then press into that so that they do self mobilizations at home because I need them to get out of the club. Okay?
Right. Okay.
So that's one of the kind of go-to that I look for, and if it's there, then I deal with that first. The second part of it is obviously the radial side of the shockwave treatment. I've recently, acquired the fascial tools, which I've started integrating. I really like those, but before I had them, which was only a couple of weeks ago, I was using the radial tool to actually go through the extensor group, especially ERCB, and getting some treatment on there. Obviously, being very that there is a nerve there that I want to be careful with. So the pressure is usually not that high.
Sure.
It's probably 1.5 maybe bars, and just working through here and doing some of the V-actor vibration therapy as well, just to reduce the tone a little bit.
Right.
So we know from all the spasticity research and shockwave, we know that it lowers the tone in the muscle. So we can use that as a tool to reduce the overall tension in the muscle, which then less compression in the tendon.
Yeah, sure.
Clinically, I see a reduction in pressure pain on the lateral epicondyle, and I never measured that, but patient reported it would be usually about half the pain.
Right.
Just
okay.
from doing those two strategies.
What do you use as a lubricant when you're using the fascial tools? Do you use the normal ultrasound gel, or do you use just a massage gel on that?
I don't know. The fascial tools I use without lubricants.
Nothing at all.
I want there to be some friction in that interface.
Okay. All right.
And then that kind of gives that release anyway. It's really efficient. I've been quite surprised really of how good they were. I wasn't expecting them to be that good.
Yeah.
We've been following all the webinars lately and seeing Carlo Di Maio and Stefan Swartz,
who's the fascial man,
actually inspired me to see if I could borrow them off one of our colleagues.
Right.
So I started with them, but so nothing on there. And then when you go onto the radial, obviously you need the ultrasound gel. Or you're not going to get any transmission of the forces in there. The next thing to look for is literally just like tight bands within the muscle tissue that you know could be influenced. So we know the common extensor tendon becomes the intramuscular septum up here, and there's usually some tenderness along the ridge of the lateral epicondyle. So if there's some soft tissue tension there, I'll radial that too. I'm quite generous with my radial. I want there to be some stimulation and blood flow bringing into that tissue.
And what do you use to start with on the? Because I know that a couple of us like using the ceramic head. Do you use a normal R15 normal metal head?
I probably do most of that with a D20. And before I had the focus, I then would go on to the ceramic head 15.
Right. Okay.
Yeah, but I use the D20 a lot for this general muscle.
General muscular stuff too. Okay, fine.
Wider area, it spreads wider. Yeah. And I just want that stimulation throughout that tissue.
Okay. And then when you go onto the insertion, then you do C15 just for the pain, the the sensitivity that's there.
Yeah, that C15 would be my go-to. It tends to give like a little bit less sensation on the skin, which is good for the enthesiopathies, the insertional tendinopathy stuff.
Yeah.
And patients tolerate that better, and it seems to give like just a little bit deeper sensation as well. I don't know if you found that, but it feels different to the normal R15.
Yeah, that it does. Yeah. Would you try and get them onto that, or are you quite happy to do the whole insertional treatment with a ceramic head?
Well, these days I go straight for the focus because I've got it.
Oh yeah, true enough. Yeah.
But I would do a good 2,000 shocks usually with 15. On tendon, the other area that I tend to go for is like 3 centimeters down the tendon as well, which has been shown to be quite a hypervascular area and an area where there's a lot of pain usually.
Right.
So I try to cover both of them with about 2,000 shocks, and then the pressure level, 2 bar up to 2.5 bar if you can tolerate, but usually it starts off quite low because of the pressure pain of that, and gradually build that.
So do you still use the radial in combination with the focus, or do you just use focus now you've got it? Both combination?
I do all the muscle work, I do the thumb work and everything with the radial, and then when I do the insertional, because it's so much less discomfort, I guess, for the patient, I choose that for the insertion.
With the big big standoff, I assume?
Pardon?
With the large standoff?
Yes. Yeah, so standoff number 2, the large standoff, so that we can get the right treatment depth. And then it's usually about 1,000 pulses with that, starting off at 0.05 and building maybe up to 0.1, 0.12. But I usually don't get any higher than that. The patients are usually very sensitive, and you have to keep that pain down. I think that's a huge part of the treatment. And like looking at the research on it as well, they've found that the low pressures actually perform better over time than the high pressure. So they've compared like 0.1 millijoules per millimeter squared to 0.25 or 2, I think it was. And there was a marked reduction in both pain, grip strength, and all the outcome measures that they used in the lower pressure group compared to the high pressure group. So, it's kind of what the patients seem to tolerate better with, but also the research suggests that is the way forward.
0.1.
Yeah, 0.1. And like I said, I start usually lower than that.
Yeah, I do. If I start at 0.05, then most patients they're feeling a bit of pain at that point, right?
Yeah, exactly. They want you to go. That's a bit much. But sometimes you start lower, right? It's all about the patient and what they can tolerate, and that there's still a therapeutic effect even at those levels. But then you gradually build up that tolerance, and you get in deeper into the issue.
And what do you, when someone comes in, I don't know the answer to this at all actually, because we've not spoken about this, whether you offer packages of care or whether you say, actually each patient is different and you've had it 5 years, you're going to need 6 sessions or whatever else. How do you construct your treatments with Shockwave? Do you have a package that you do, or do you say I
don't tend to sell packages, but I do inform them of what our outcomes are that we're trying to achieve, and so for me, Shockwave, it's a healing accelerator, so we want to upregulate all that biology that we're working on, the tissues that we're trying to treat, and you kind of need a few steps to get that going. So for the tennis elbow, I usually would start with 3. The research kind of suggests that you need 3. So we start with 3, and then we start the rehab as soon as we can. So the rehab might be genital isometrics after the first one, because it has to be low on the pain scale. But genital isometrics is usually well tolerated, and it gets them going. And we know that in the short term at least can give them some pain relief too. Then we go through the 3 sessions and gradually introduce more loading locally. And then when we can, we start to then integrate some shoulder work and some shoulder blade work as well, because we want to improve the strength there. We want to improve the central stabilization through there. And then after 3 sessions, we leave it a couple of weeks. Then I have them back because I want to progress the rehab. And we then, look at what's going on here. Is this pain still a big part of it? Then I would go, we're going to do another stimulation on there. And then I have them back again 2 weeks after that. Monitoring the rehab, changing things, progressing things. And hopefully by that stage, we've got them doing some hanging, gripping, holding, and things like that for the more active group, and twisting the towels and doing other things, press ups and things for the less active group. And if it needs to be, then we will top it up again. We want just that healing stimulation to keep on going. But then after that, we kind of have to leave. We know that it lasts a few weeks with the collagen turnover, everything like that. So we want that process to take place, and it's about monitoring the rehab and progressing as appropriate. And then, we might review it after 3 months. But most people, touch wood, are a lot better by then, and they kind of decline treatment.
Okay. So when I teach the research stuff on this, and it always comes back that the lower extremity stuff does particularly well with Shockwave, the weight bearing tendons, and tennis elbow is always like the poor brother over here, and I think partly that's because there is less research on tennis elbow than it would appear. Achilles, plantar fasciitis, they're the ones that always get the shining light. Do you think it's the lack of quality research that suggests it doesn't work that well, or do you think that there are differences between the nature of tendinopathies in the upper and lower extremity? What do you think on that? Because you're clearly getting good results, right? So I think when
it appears that way, doesn't it?
Plantar fasciitis, everyone sort of says, look, we can confidently say the average outcome, 75 to 80% of people get 75% better within about 3 months. But with tennis elbow, certainly when I teach it, I sort of say to patients in the room, and I say to people when I'm teaching them, look, it's a 50-50 thing more than it is 75-80. But by the sound of it, you're getting better results than that.
Well, I think, if you look at the research, it kind of reports, there's a mixture really. It's kind of between 65 and 90%, depending on which paper you read.
Right, okay.
I think, there was a great position paper by the Good as Maya group and the kind of the ISM and the T guys back in 2017, when they kind of look, is this the main indicator for Shockwave, the tennis elbow? And they reviewed a lot of the old research, because a lot of people kind of read the early stuff from like the early 2000s and 1990s and stuff, and there was just such a great array of different treatment modalities happening at the time, and there were different machines, there were different settings being used. Somebody used one setting, one treatment session. Some people use 3. Some people use high, low, different electrohydraulic stuff, piezoelectric machines. So the research was all over the place, and quite rightly, there wasn't really a huge support for it in the early days. But they kind of looked at it, and through up to 2017. There was still a majority of papers that suggested that it's a really good treatment as a second line for tennis elbow.
Right.
Why is it so different to the lower limb, right? Because it is different. I think the complexity of the upper limb in terms of how it moves and stuff is greater than in the lower limb. Yeah. I think that's part of it.
Yeah.
I think often it's a case of underloading. I think they're scared of loading the upper limb. The lower limb gets lots of load because it has to for running, jumping, and all those things. I think in the upper limb, people are just a little bit careful with it. There's a lot of isometrics and therabands, and that's often where it stops with tennis elbow.
Yes, I might be guilty of that.
I think there needs to be a much more holistic view on it. You have to look at even into the chest, the core muscles, how they're functioning together, how the shoulder blade is, can you control your scapula in space?
Yeah.
And that, all of that, how that influences the pressure and the tension that comes through here. And that gives it a different challenge to a lower limb, which is usually brought on by repetitive overload, which becomes a much more a loading and capacity issue. You have that in the tennis elbow too.
Yeah.
But there's just a much more complexity in terms of what's going on at the hand, the shoulder, and all the muscles in between.
Right.
That's kind of my take on it.
Yeah.
I'm not saying I don't get 100% success rate with them. Sometimes we need to do a second lot of Shockwave as well, and that then further improves it. Not everybody is a quick responder on early, from these treatments.
Yeah.
But you have to realize what's going on here. Where are we at in the rehab? Are they adhering to it? is it worth then doing another 3 sessions? Let's get back on the rehab because you've kind of slacking it off a little bit. And there has to be that patient and therapist partnership too.
Yeah.
And you have to be pretty honest in your approach.
And on that note about, you know, those patients that don't respond, they're the ones that ultimately we should be learning from, you know, about what do we do not do right. When you're seeing patients sat in front of you and you're thinking, you know, this is a good candidate for Shockwave, are there particular patients where you started to think, I'm not sure that's going to be a great outcome, or I think that type of person is going to be a good outcome? I mean, do you have a sort of patient selection thing in your head where you're starting to think about that as much as you've anecdotally experienced it?
I think people who are used to training get the rehab.
Right.
They're usually quick responders.
Yeah.
The other thing that I do as well, you know, I've done my kind of basic ultrasound training, and done some advanced training as well with the SNUG group, which I've found very valuable. And so, you know, I've learned how to scan a tennis elbow and the most common tendons that I see.
Yeah.
And you know, I can kind of pinpoint a little bit and see how bad it is. And you know, if I see a majority of the tendon is affected, then I know that there might be slow responders. If there's a small area that's there, then I know that they might be responding a bit quicker.
Yeah.
For instance, if you see calcifications in there, that might influence things a little bit. And if you have a tear in there, you know that Shockwave, they actually do worse than if there wasn't a Shockwave.
Yeah.
Worse than even with exercise. So you might stay away from Shockwave at that point in time.
Yeah.
And those kind of people often go on to surgery in the end.
Right.
So there's multiple factors involved there. I think, you know, the other thing is, you know, the treatment is very safe.
Yes.
You know, there's no risks involved there. So if the patient agrees to it and you come together, it's going to be the treatment plan, then you know that you're certainly not going to harm by doing the Shockwave.
Yeah.
But like I said, most of the time they do respond. They get that gradual reduction in pain over the first 3 sessions, and everything's happy. They can recruit the muscles better. The rehab starts to flow better, and they start to get confidence in themselves, which then further kind of perpetuates the rehab progress through it.
Okay. All right. I think that's covered most of the things that we were going to talk about. I think what I've learned from this is I'm incredibly lazy myself with tennis elbow. I think I got myself into some sort of myopic looking just at the elbow stuff, but you know, I'm excited about coming to work tomorrow. I'm going to look at people's thumbs. I've never done that before.
Yeah, no, absolutely.
And even as an osteopath, I was taught some of this stuff. I've got 20 odd years ago, and I've got a bit lazy on that. So that's been really useful today. I think actually, it's probably no wonder why I haven't got great results with elbows, because like all these things, it comes down to the difference between your management and the rehab, not just the magic machine that we might have, right? So.
I think you're right there, but I think, you know, the goal dust probably is that your arm is there to position your hand in space.
Yeah.
Okay, to interact with the environment, whether that's on a computer or whether it's hanging from a bar or throwing a ball. Yeah. And you know, this is just one part of that.
Yeah.
And so you know, looking at the individual parts and making sure that they have the prerequisite movement. Yeah. It's a really, really important part of it.
Super. Right, we're going to go home and have some tea now. So, can I thank you very much for coming on and giving up an evening for us.
To be here, mate.
We're going to be, hopefully, if this is all recorded as it should, this will be on YouTube and it will be obviously on the podcast. So, I'll sign off now and thank you very much. Cheers.
Thanks, James.
Bye-bye.
Bye now.